everyone. Welcome to the Wheeler Centre this evening. I'm Madeleine Morris. I'm the host of the Question Time series here at the Wheeler Centre. It's a series that we do pretty much every month on various topics. And look, it's a really great discussion that we can have tonight. It's been sold out for months, I think, which shows the level of interest in this issue of compassionate healthcare, because there are two things that are certain: death and taxes, and also a third thing, which is at some stage we're all going to have to interface with the medical system. We all do get sick, but how well does that system actually serve us in terms of not only our body but us as a whole person? These are really key things to talk about. Does whether we are rich or poor affect the type of empathy that we get from our practitioners? As we become more technically and medically advanced, are we keeping up with the need to remember the whole person? So how compassionate is our healthcare is what we're going to be discussing tonight. Another thing we might get into is what specialist fields are best at being empathetic and compassionate. Are some better than others, and why is that? So we have three people here this evening who all have expertise in this field. It's expertise based on very different and rich seams of experience. I'll start with Ranjana. So Ranjana Srivastava, she's an oncologist, a Fulbright scholar in ethics, and she's also an award-winning author. Her books are Dying for a Chat, The Communication Breakdown Between Doctors and Patients, and her latest book is After Cancer, A Guide to Living Well. Lucy Cuddihy is the Chief Nursing and Midwifery Officer at Barwon Health in Geelong. She's also an adjunct professor at the Deakin University School of Nursing. She sits on a number of health-related boards. And Kate Richards is the author of Madness, a Memoir, which explores her long experience with acute psychosis and depression and her journey towards managing it. And she's also a qualified doctor and is now writing fiction full-time. So I think what I might do is I might just start off with you, Kate, just to explain for those who aren't familiar with your work how your experience of compassionate healthcare came to pass and your interface with the own medical system.
Sure. Thanks, Madeleine, and hi everyone, and thank you so much for being here. I had a dual experience, I suppose, that at the same time that I was studying medicine with Ranjana at Monash University, I was also experiencing the healthcare system as a patient in a couple of acute mental health units. So I guess I saw both sides of the coin in a way. And although I was training in surgery and general medicine and geriatrics and everything else, my personal experience was very much with our public mental health system. And I think, look, in all areas of medicine, compassion is not just a kind thing, but it's a healing thing. And particularly in psychiatry, I think that compassion was shown not only by doctors, but also most particularly by the mental health nurses, some of whom were absolutely instrumental in my healing journey. But look, also the social workers, the cleaners, the people who were serving us food. Sometimes when you're in such a dark place, just a smile or a very genuine "how are you," where there was a chance to actually say something meaningful in return. And I think also the greatest gift actually that any of the healthcare staff gave us in those mental health units was that they listened, that they just gave us some space and time to talk, and they listened without a kind of any return agenda.
And I was going to say time, you need time for that, don't you? And yeah. Time is something that we find is often in short supply to a greater or lesser degree in most areas of medicine.
Look, absolutely, and that's not the fault of the health professionals who were trying to do their best at the time. It's got a lot more to do, I think, with our overall healthcare system. But certainly I think an articulation of hope and kindness, empathy, they were for me as a patient absolutely as important as whatever particular medication I might have been taking at the time or whatever particular diagnosis I was given.
So, Ranjana, you continue to work in a hospital, and you have such a vast range of experience, not only on the ethical side and on the author side, but as a practicing oncologist in an area where people need a lot of compassion. Are doctors able to provide, and nurses, the compassion that they want to? Are they in a position? Is that structurally available to them?
Thanks, Madeleine, and good evening, everyone. So that's an interesting question. And I guess I almost think if you start with the premise, do we have time to provide compassion, you give people a choice. And you say, well, maybe I don't. And I think that whole construct shouldn't be the case. And there's, an old saying in medicine, the patient doesn't care how much you know until he knows how much you care. And that is so true. And, time and again, I find myself reflecting on the fact that for the first maybe 5-10 years of being a doctor, I was so stressed about what I should know in terms of the literature and the knowledge base, that bit about caring for patients shouldn't have been secondary, but it almost was, because when you're so stressed about trying to remember the name of the chemotherapy or how to treat patients, and as a medical student and as a doctor, that's what's emphasized in most medical courses, is how to become a competent doctor. And I think, what I feel is that in a first world country like this, if you have studied medicine in a good system, your competence and your knowledge is hardly ever an issue. And repeatedly on a daily basis, what our patients are telling us is that it's the art of medicine that is lacking, not the science. So I really don't think that we have a choice about compassion and empathy, etc., and they need to be elevated universally.
Mm-hmm. And Lucy, you were a nurse for a long time. You're now in management. How important is teaching compassion? I mean, you know it's important, but how do you actually go about doing that on a practical level when you want your staff to show compassion?
So the teaching of compassion, that really starts in the undergraduate programs. And so I think that it's well recognised now in schools of nursing and other areas of health that, in fact, person-centred care, it comes first and foremost. And in order to bring that to life, then people use a range of different techniques, whether they're case studies that are about a lived experience, such as Kate's, where the person is able to tell their story. Less actors are used, and more indeed the story of the person and the patient informs the case study. That then enables a range of emotions to be not only considered as part of the learning experience, but indeed in high fidelity simulation environments. Mannequins, you can have a mannequin cry.
And this is in an undergrad program?
In undergraduate programs. Yep. And so that's, I think, really important in undergraduate programs, and to really affirm our interest in continuing to make sure that empathy is front and centre. I think from a health service point of view, we employ 7,000 people. We employ against our values, one of which is compassion. So as Ranjana said, we take for granted people have the technical and the expertise necessary to be shortlisted for a role. When we interview both medical practitioners and all other clinicians, we employ against our 5 values, one of which is compassion.
And how much has that changed over the last
Enormously.
10 or 15 years?
Enormously. That would be 5 years that we have introduced it. We introduced it through the nursing line first of all, then we took it out to the health, our allied health colleagues, and now in medicine, it's our first year HMOs. That is the way that we interview for them to commence their career is against our values.
Are you seeing that change as well, Ranjana, in terms of changed attitude of culture about compassion?
Yes, I think you are. And, interestingly, back when Kate and I did medicine, for example, if you got the marks, you got into medicine. And it was taken for granted that you had the people skills to be a good doctor. And clearly, that has not proven to be the case, and you can be highly intelligent and yet not know how to practice the art of medicine. So I think that's changing. The question always is, what is the best tool to find someone empathetic amongst lots of high achievers? And I think it'll always be an imperfect tool. And so I think that things like compassion and empathy, to some extent, maybe to a great extent, come down to personal integrity. And if you enter medicine, if you enter any kind of a healthcare job, then, and if you don't value compassion yourself, I think it's very difficult for a system to screen in and screen out these people.
Right. That sounds like a bit of a flaw in the system if you're unable to screen in and screen out.
I don't know if it's a flaw in the system as much as you can perform to an interview. It's a 15-minute interview where you can say things that make you appear kind and empathetic.
That's true.
All right, let's get some questions and start it rolling. Who have we got?
Ranjana, Lucy and Kate, it's very exciting to see you tonight. My name's Anne. I'm a registered nurse of about 32 years and I work with asylum seekers at Asylum Seeker Resource Centre. Ranjana and Lucy, it's lovely to see you, but I have to say that, Kate, you're my professional pin-up girl. I read your first book a few years ago and I still carry it around in my tablet and refer to it many times. I've worked with people with mental health issues and in palliative care and critical care and for many years, and it wasn't until I read your book that I truly, truly understood what it was like to have a mental illness. And it also showed me how to be a better practitioner, also a better mum. So I thank you very much, and thank you for giving that gift to us from the journey that you've been on. And I would recommend that every single healthcare student and practitioner read your book again and again and again. Thank you.
Thank you. That wasn't a question, but can I second that emotion, because I have to say, absolutely, reading Kate's book was a revelation for me personally in what it's actually like to live with a severe mental illness, and the way that you described it was extraordinary and beautiful and deeply touching. And I think I would completely agree that not just everyone who works in the field of medicine should read Kate's book, but I think everyone, period. All right, so that was a very nice place to start. Do we have a question?
Hello, I'm Mary Tian and I'm a consultant into workplaces on compassion. I did my Masters in Public Health at La Trobe and I developed a model around the compassionate workplace. There's quite a lot of work being done around compassion. It started off in the States actually, at the Schwartz Centre, and Robin Youngson from New Zealand has also done a hell of a lot of work as a doctor around compassionate workplaces. I actually think it's not just an individual one-on-one issue. I think it is a systemic and structural issue. And, excuse me, having a long-term background in palliative care, I've seen the lack of compassion coming into something that's usually a very human experience, which is death and dying. Part of the La Trobe model is to push it upstream into when people are diagnosed with a life-threatening illness. And there's some fantastic resources around, even in the Small Business Victoria, of which I was one of 4 women consultants who developed some resources that are online. They're free for anyone who's a business owner, who is either an employer who has a life-threatening illness or who is an employed carer or an employed ill person.
Did you have a question, Mary?
I do have a question. I want to know what is being done within the medical profession around the systemic and structural problems that exist in the healthcare system around compassion.
Well, do you want to start, Ranjana? Because Lucy talked a little bit about it before. Yeah.
So I think specifically in the area of oncology and palliative care, we are genuinely understanding, I think after a very, very long time, about the importance of compassion and empathy, and it is being taught better, it is being spoken about, and it's also being role modelled. And, you know, we have, for example, palliative care nurses or pastoral care workers, and also doctors. There are wonderful oncologists, palliative care doctors around the hospital system who are modelling this for their students and their registrars, etc. And I think there is no greater way to learn compassion and empathy than A, by watching someone do it, and B, then by practicing it and by feeling gratified about the difference that you can make to a patient's life. And I think the more we begin to speak about such things, it becomes fashionable to hold a patient's hand and to actually sit at the bedside and talk to patients. And so, when people say, I want an old-fashioned doctor, what they mean is someone who will sit with them and talk with them and not just stand at the foot of the bed and sort of stare down at them or hover at them. And I think that's happening. Medicine is very complex. It's changing a lot, and the technological advances are such that they're galloping along. And it is very difficult for the modern-day clinician to fit it all in. And it didn't used to be so hard. Even when I was a registrar, there was less to do for cancer patients. There were less treatments. There were less interventions. And so at some point in time, you had to stop and regroup and say, there really isn't much else we can do except be kind, compassionate, and support people at the end of life. Now, one of the flip sides of having these great technological advances is it is actually possible to say to a patient, there is something else we can do, and then there is something else and something else. And that's why I think it's important to step back and say, well, there may be drugs we can throw at people, and there may be another CT scan that we can do, but is that what the patient needs? Mm-hmm. And I really feel that there's much greater appreciation of that than there used to be. And whether we will see it achieve the heights we aspire to remains to be seen, but it's good that we are talking about something like this.
How are you able to measure that though, Ranjana? I mean, there's not like a box that you can go, did I show compassion today? Did I wash my hands? Yes, tick, tick, tick. I mean, and as student doctors, is that something that student doctors are actually measured on? And is it possible to do that? And as people go through continuing training, is it possible to do that?
So that's a fabulous question, and it's to the heart of why doctor-patient communication takes a back seat, because you can't measure it. You can measure how many MRIs you did if you bought a new machine. And if somebody cuts a ribbon and there is a new machine, or you open 10 new beds, you can numerically say what happened in those beds. How many elective operations did you get done? The problem with qualitative things like doctor-patient communication, although we know that 3/4 of the complaints in the complaint system are due to communication. They're not because someone operated on the wrong leg or the wrong breast, or someone prescribed the wrong antibiotic. They are few and far between. Mm-hmm. So I think part of the problem with employing robust sort of communication, firstly strategies, teaching people, and secondly monitoring measures, is that it's difficult to monitor. But what I keep coming back to is, when you've done a good job with a patient, and the patient knows when they've had a good rapport with the doctor. And Kate's book is full of bad examples of poor communication where she felt hollow, and then good communication. And so asking the patient is a good start about what the environment in the hospital is like, or how their healthcare providers are communicating. But it's a tough one to grade.
Sorry.
I was just going to add to that I don't know if it's done anywhere here in Australia, but one thing they are doing, I think particularly at Johns Hopkins in Baltimore in the US, is that on that original form that you get when a patient is admitted from, say, emergency to a ward, or from home to a ward, there are 3 questions that you need to show that you've asked the patient. The first one is, what is your understanding of what's happening with your health right now? The second one is, what's most important for you that we could do for you while you're here? And the third one is, what do you hope for?
Really? And that's a standard form that everyone has to fill in?
Well, along with all the things like physical examination and blood pressure and all those other things, provisional diagnosis, medications that are part and are taught. We all know as medical students the list of things that you must go through when a patient is first admitted to the ward. And I think, I don't know, it might well be being done here, but I just think that is just a wonderful way of making sure that the patient is then involved And not only that, that then the health professionals, when that person goes off duty, who's actually asked the questions, if they've made some notes, then they're there for the person who follows on in the next shift and for the consultant that comes on in the next morning.
So many healthcare facilities, mine for example, our organisation has a goals of care form. And the goals of care form is supposed to, I suppose, gather the answers to those questions. I think, and it's great because we never used to have anything like it. So we're getting closer to at least eliciting people's preferences and goals. The question then becomes, how deeply are you interested in the answers? Right. Is it a tick box? Yep. What are you expecting to get better? Or is it something deeper and more meaningful? And I think it depends on who delivers the questions. So we have those forms, and it's always the practical translation of these things. The devil is in the detail.
Yeah, it's true.
Do you have a form saying what do you hope for at Barwon Health?
It's not what we hope for. We certainly have goals of care. And I was thinking about Mary's question, really, and the structural things that we're doing. And we are, you can do the one-on-one, and the one-on-one is really what Kate is saying, but how does that build into a system, and how does the system change? So we're struggling with this, but we're indeed struggling with it. And so we choose a range of strategies to either educate our board or ourselves, because it's important to lead in this space and bring to the board. For example, last month I had one of our palliative care consultants speak to the board on compassionate care, and what does that mean in our setting? So that was actually delivered last month to the board subcommittee on safety and quality. The patient stories, we don't only highlight good stories, we absolutely do warts and all. And we have a very strong and robust process around gaining consent for that, because some people don't want to consent. The other thing is the consumer rep programs that we have in organisations now, I think are delivering in ways that even 3 years ago they weren't. So I think there are structural things that we're attempting to do. They mightn't be complete, but they are about really going to the essence of what does person-centred care mean in this organisation at this time, and then what do we need to change and improve it.
Okay, next question. It's funny, while someone thinks of their next question, I just thinking about what an old-fashioned doctor is. I remember when I developed appendicitis when I was living in the UK, and my very old-fashioned Irish doctor, as I just burst into tears. He said, "What are you crying for?" And I said, "Because it really hurts." And he says, "Well, stop crying." And to me, that's the definition of old-fashioned medical care. Whereas my lovely young doctor was like, "Oh, we'll get you to hospital," rubbing my back. Just stop crying. Yes, down the front here, please.
Thank you. Hi, I'm Carol. I have the greatest GP in the world, can I let you know, so I'm really pleased about that. However, I had cause to be admitted to hospital, and I had 7% lung function at that time. I was put into a ward that couldn't supply oxygen. And after I had got better, because they rushed me back to emergency, I questioned the fact that they put me up to the ward. Now, my question is based around patients who complain, because after that point, I didn't complain, I just said, "Could you explain to me why this has happened? Because I nearly died and I want to know why." And I did it very gently. However, from that point on, I got real cold shoulder from everyone that treated me. So I want to know how medicos are being trained to deal with complaints and not punish the patient for complaining.
I'm really sorry for your experience, and it shouldn't happen if that's what happened and your care was inappropriate or inadequate. Then I think someone should have explained why, and certainly it's neither pleasant nor something that any organisation would be proud of. What are we doing about it? I think that role modelling is important, and I just wonder about the sort of role models that the people who gave you the cold shoulder have had in their training. And I sometimes wonder also, taking the opposite side of it, doctors behave in certain ways because of experiences, like we all do, because of experience that they have also had. So one of the, we talk a lot about open disclosure. When we make mistakes, we need to go and speak with the patient. And all the research shows that when you make a serious error and if you go and speak to the patient is far less likely to take to take action, to sue you, and it works out better for everyone. But I think, leaving aside very serious situations, I think sometimes accepting that someone did something wrong or you did something wrong, people can still get angry at you. And especially when you're a young doctor or you're a junior doctor, I think sometimes the lesson you take away is, well, maybe telling the truth wasn't such a great idea. It's not the lesson you should take away. And if you had good mentoring, you shouldn't. But I think when you're young and someone has I'm not saying you did, but someone has an outburst and doesn't listen to you, and they're really, really angry that their health was compromised, and you're thinking, well, I'm trying to do the right thing here by either explaining, apologizing, but,
This was an older
right.
specialist.
And then I think that there is unfortunately a section of the medical population, which I think is dwindling, in fact, doctors who feel that they shouldn't be questioned. And I think they really are a dying breed. I work with colleagues who are growing up in a different culture. They're growing up in a culture which has a Wheeler Centre program like this. I've never seen anything like this before in the last 10 years. We were talking about compassion and accountability in healthcare. So I think it's coming. And I commend you for doing the right thing, because even though you were the object of cold shoulders, I think what these experiences do is they teach us how to behave better the next time around. And I'm sure that the people who didn't behave well towards you, in some corner of our hearts, we all reflect on our day and what we could have done better. And I sincerely think that when we know we have been the cause of a bad experience to a patient, even though we are obstinate and not accepting it in public, I think it does give us pause for reflection.
Can I ask what the effect of that cold shoulder was on you? Did it?
It was when I went back to see the specialist after, I think it was 3 months, to check that my lungs had started functioning again. And I walked in, he said, "Oh, yes, sit down." And I, asked some questions, and he said, "Yes, no, yes." And it was like, and I said, "Well, where do I go from here?" And he said, "Out the door." And it was like, okay. And he said, "If you're still suffering in a year, come back and see me." And I thought, if I'm still suffering in a year, I'll be dead by then,
And did you take it further, the complaint further? Or?
I didn't take the complaint further because I thought this is not getting me anywhere.
Yeah.
But I didn't even... I was persuaded to put it in writing by the nursing staff. And having done that, I then got really, difficult behaviour. So I went through my GP, who was absolutely wonderful, and he ensured that my care was sufficient.
It makes me think, Kate, of your book and how kind of random it can be, the specialists that you end up with. And you really, you get referred, for example, and you just don't know what kind of rapport you're going to have or how competent that person is. And you went through, a baker's dozen of psychiatrists at various stages, didn't you? And how much did the lack of compassion shown to you by some, how much did that actually affect your own outcome?
Yeah, very enormously. Just reflecting on further on your experience and on what Ranjana was just saying, I think we have to go right back to medical education and the way that medical students are trained. And I know it's a lot better than I think it's a lot better than it was when even we went through, but there really is a culture of if you get something wrong, that's a shameful thing and it reflects badly on you personally, and it's not something that was much discussed. And you know, even as students, the incredible pressure there is to learn everything quickly and to be able to spout it back out correctly, and how dreadful we were made to feel if we got something wrong. And then there'd be no discussion around that, but you would be made to feel quite like you'd like to dig a deep hole and cover yourself over. And so I think people have gone through 5 or 6 years of that kind of learning, and so they're tremendously fearful of making mistakes, not just because that has an outcome on the patient's health, which is the most important thing, but also it may reflect on the way their colleagues see them, the way the nursing staff view them, their reputation, and coming from a place where you're very afraid of sort of looking human rather than sort of vaguely godlike.
Which also comes, the doctor knows best mentality as well.
I think because of that, I can absolutely see why you may have been given, as you put it, the cold shoulder, because these people don't cope well when they make a professional error, and it's ingrained. And I do hope that we're getting a lot better at being able to talk through situations. And it is risky, exactly as Ranjana was saying, that it's quite hard to sit down at the bedside and say, look, I did X and I should have thought through about Y. And but I think, you know, it's got to start back in first year medical school, where this culture of fear, if we could sort of move on that, and like Ranjana was saying, the idea of role models is so important.
Which, as Lucy was saying, you know, modelling and role playing, I suppose, is different from role modelling. Did you want to add something to that question, Lucy?
No, I can't imagine a situation where there isn't oxygen, though. So that is quite an extraordinary experience you've had. And we work with open disclosure, as Ranjana has said. We train our medical staff in open disclosure techniques. It's not universal, you don't have to attend, but certainly we do. And not only our medical staff, but indeed, you know, it's about teams. It's about how teams perform. And, you know, in that circumstance, I'm not sure of what the circumstances were. I'd like to know where the team was.
I'm proud to say that I was Kate's therapist. And I'd done some training also at Peter Mac.
Winsome.
Yes.
Yes.
At Peter Mac. And I can remember vividly an occasion where I was sitting at the bedside of someone who was about to be discharged. And I asked the doctor if I could speak to the patient, because the doctor takes precedence. And so I inquired a whole range of things about this person, just kept asking and asking and asking. And the doctor turned to me at the end and she said, "Where can I learn to question like that?" And I said, "Well, it's been part of my training as a psychologist. And I want to know why this is not compulsory for every nurse, every doctor, at some stage, and the earlier the better, in their training, because I think learning how to listen rather than give information and try to provide answers is absolutely paramount."
Anyone have a comment on that?
I think the glib answer to your very good question, Winsome, is that the administrators would say that there is so much information to pack in to a medical or nursing degree that there is never room to make ideal room for these very important topics. But I think the issue you raise is important, and it goes to the heart of how we design a curriculum and what we think is important in a curriculum. And one of the tensions between clinicians and universities tends to be the universities design the courses, the doctors come to the hospitals. And the hospitals say, you know, the students have had very little training in palliative care, for example, and hospitals say, well, a week of palliative care training is not good enough. And the
Do they only get a
universities-
week of palliative care training?
Well, a week or 2 weeks or a couple of lectures on communication, compared to things like anatomy or physiology, etc. They are small. But then, it is, and I'm very sympathetic to the tension, because you also want your doctor to be competent. And there are so many people out there who will say, I don't care if my surgeon doesn't talk to me, I want him to operate and get it right. So there is that, but they want someone else to do the talking. They forgive the surgeon. But people say that. People say, I want technically proficient people who know when they see an appendix to get it out. So there is a genuine tension of how much do you fill a course with the technical expertise, without which, you can have the kindest doctor, but if they're not competent, it's a real issue. They'll fail you in the end. And to get the balance right, I think, is going to be an ongoing process, and it's going to be different for every society. It's going to be different for every culture.
It's interesting, though, just talking about the need for training in various aspects of empathy, in this case in healthcare. I emceed last week a National Family Violence Summit and in Canberra, and one of the key things that we were talking about was we wanted to get recommendations of what people wanted to change. And one of the most key messages that came out was not about more funding, which I thought it would be. It was about more education for people who interface with people who experience family violence. So in how to, the right questions to ask, what they actually need. And this need for more education and more understanding is so key to so many aspects of life, really, isn't it? And there seems to be never enough time and never enough money and so much that we need to get done, that it just seems to, these kind of caring things often seem to go to the bottom of the pile.
Yeah, it's such a paradox, because I think now we are doing some research to prove that if you establish good rapport with a patient and you educate them well in what's happening to them, and you get them to ask you the questions that they need to have answered, that further on impacts on how well they heal from whatever it is, how well they manage a chronic condition in the community, how compliant they are with taking medication or whatever other kind of treatment regime you might have put to them, and also for patient safety. I think one of the things that I saw happen many times, particularly in mental health, but I think it happens in a lot of other areas of medicine and also in oncology, or whenever there's a complex situation that's being dealt with, is that a patient gets discharged reasonably well from a ward and goes back home, and I think we're getting better, but the GP then gets some sort of discharge summary that maybe says a few of the things that went on, but not an enormous number of the things that went on while the patient was admitted. The patient goes home without a clear understanding of what's actually happened, and then we expect that patient to manage whatever that was on their own, or perhaps with their family, who are also possibly confused and frightened. So I think it's more than just compassion and empathy. I think it extends right through for really the rest of that patient's life.
It affects clinical outcomes.
Yeah, and I know they're trialling now in Melbourne, where they actually do a discharge summary. They video the discharge summary, which is between the patient's family, if there's anyone, or carers that they'd like to be at the bedside, and the registrar or the consultant, and they actually videotape that, and it's a conversation rather than just the clinician telling the patient and family, and then that is sent to the general practitioner, a copy of that file, and also given to the patient and or family members if they would like to have it, so that then, because they get so much information so quickly and it's so overwhelming, they can refer back a week or two or a month or 6 months later.
Great idea. That's a fantastic
And I think it's wonderful. It also, there's no confusion then about what the doctor did or didn't say about what's happening for the GP and for the patient and their carers.
All right, next question down the back.
I'm Ross. Wondering if you could discuss whether clinician burnout is a factor in the lack of compassion, and if so, what are some things people and organisations can do about that?
Do you want to pick up on that, Lucy? And then
Yeah, I think burnout is a matter that's been well researched, and so there's a lot of information available. One of the things about health, and in fact being a nurse, is in fact you can actually move through the health system, and in fact you can move to a range of other roles, and you might need some additional training, but it's possible. And so I think nursing in particular enables you to not have to stay with the environment if indeed you're finding that it's not tolerable. So I think that's good, and I think we're aware of it. And do we measure it in the organisation? No. Do we give people time out? Do we have employee assistance programs that involve psychologists and various others to work with our staff? Yep. Do we think about ways of assisting our staff to debrief from certain, critical situations? Yes, we think about that and we do that. So there are some things we do. And I think the different professions, I think what Ranjana does in terms of her writing and her creative writing clearly gives an opportunity to...
Not creative, it's real.
I know, but it's
she's not making it up
to read. It's good to read, as is Kate's.
But as an oncologist, I mean, God, you see dying people all the time. How do you deal with that? And does that affect how you can actually care for them?
So, 2 questions ago when we were talking about how medical students, when they don't perform, are made to feel bad. The other thing I immediately thought about is that even when you don't make a medical student or a junior doctor feel bad, they are feeling bad because they're such high achieving people who have spent a lifetime trying to get into medicine. These are kids who were at the highest performing end of probably their primary school, their secondary school, certainly their high school years were occupied by the thought of becoming a doctor. These people enter medicine, and society places such an enormous responsibility on these kids. And then we sort of elevate doctors to such a high place that it really hurts to fall. And so I think we set ourselves as a society, I think when you value doctors, or you elevate doctors to such high degrees and not, say, for example, teachers. I think we are creating a system where doctors will find it hard to accept blame and to fall because it hurts and because that's not what's expected of them. Burnout is a huge issue, and I think it's certainly something that is being talked about more and more because I do think that the challenges of looking after increasingly chronic, complex patients, the single system patient doesn't make it to hospital anymore. So when I was an intern, you would treat a 60-year-old who had pneumonia. They would get better, it would be a happy outcome, they would get home. These people don't come to our wards anymore. They're sent home on antibiotics. So what we see is the 89-year-old delirious patient who has heart failure and a urinary tract infection and has a fractious family, and her husband is also dementing, and the kids are at work and they don't really have the time to come in, although they're very sympathetic that somebody needs to attend a family meeting. Day in, day out, you see 30 of these patients. It's taxing. So what do you do about burnout? I guess the thing is to accept that there is burnout, and medicine is not very good still at accepting and encouraging its own profession to say it's possible to burn out, it's okay to burn out, and we need to look after ourselves. Secondly, for me, I guess I have found an outlet by making a deliberate decision to not work full-time in oncology because I don't think I could give off myself every single day dealing with very complex patients. But many doctors do, and they're getting burnt out. I write, I find it very therapeutic. I think there are many ways in which you can avoid burnout, but all of them hinge on firstly recognizing that you're at risk of burning out and that this is a profession which isn't going to slow down, and also talking about burnout in the general community, but especially in medicine, is really not fashionable. So I think it does take some personal reckoning.
Ross, can I just go back to you? Are you actually a doctor or a medical student? Allied health, okay. Is that something that is an issue for you in allied health as well, burnout?
Sorry, I have a loud voice. I thought I could do it without the microphone. No, I've just seen it a lot, and I think I don't think you're taught undergrad or postgrad about how to deal with the unloading from people in terms of how they're going, and you have to ask those questions. And if you genuinely do care, you have to. You get a lot of that, so you have to learn how to deal with that, and what do you do with it if you are going to a level that's not just tokenistic. You have to preserve yourself as well as a practitioner. And I just don't think it's taught. And I was just curious. I think it's a factor in this.
Yeah.
So you see it everywhere. All caring professions, I think, suffer from it.
Yeah.
Yeah.
All right. Next question. Oh, hang on. Yep, on that side. I can see the lady in the middle there, and we'll go down the back, and then we'll come to you.
Look, my name's Charlie. Thanks for having me along. I just wanted to ask you a question about gender and compassion. I noticed that... I won't stand up because I've got a computer on my lap. But there's about 80%
why are you
women.
standing up, Charlie?
There's a computer on my lap, sorry.
Okay.
I'm taking notes on you.
Are you sure you're not hiding?
No, I'll stand up now. She's back. So there's about 80% women in this room, and I'll preface my question to say that I was brought up by a single mum who was a doctor. But look, there's obviously quite an interest from women in this room about compassion, and are we not doing enough to teach men compassion the right way? And look, personally, I think men probably would learn compassion better from male role models if they're challenged by the issue in the first place. So what's being done in that space? And as three women, how do you guys see men as compassionate doctors and patients?
That's a very good question. All right, Kay, why don't we start from you?
Yeah, it's a really good question. I've seen good and bad, I suppose, like I'm sure we all have. A number of the most compassionate clinicians that I've ever seen working are men. Both of the ones I'm thinking of are older men who have a wealth of experience, but perhaps also, I think, an element of being very sure of their place and their status, and they're able to kind of relax a little bit and spend more time with patients. I also think that, slightly sidestepping the gender issue, it really depends on whether you have a genuine interest in human nature and in humanity and the human condition. And I think that both men and women share that, and I think for those health professionals who have that, I think it probably makes the compassion and the empathy a lot easier to kind of bring forth every day in their practice. I've also seen some, it's tricky. I mean, I think I've seen both men and women clinicians who've shown 0% compassion, probably more men, but then there are more men who I probably have come across practicing medicine. Mm-hmm. I've come across some absolutely amazing male psychiatric nurses, just extraordinary human beings.
That's a hard job.
Yeah, incredibly. I think one of the hardest jobs there probably is. Mm. And in psych nursing as well as in emergency care, there are more male nurses, I think, than there are in some other areas of healthcare. So
you're not saying you wouldn't feel comfortable saying that in your experience, or let me change the way I ask the question, would you feel comfortable saying in your experience that women are more compassionate than men, as a massive generalisation?
In my personal experience, I wouldn't be comfortable. It really, I think the difference is women seem to be, as reflected tonight, more interested and keen in the development of our understanding and practice of compassionate medicine. If I think of the patient and family-centred care community in Victoria that I do a little bit of work with now and again, the clinicians who are driving that are women, and I'm fairly certain it's a small organisation, but I'm fairly certain nearly everyone who works there are also women. So I guess that reflects.
I'm interested to get both of your responses, and we don't have very much time left, so I'm going to ask you to be brief so we can get one more question.
So I'll be really brief and just say 8% of the nursing workforce is males, and I always greet the new males, particularly the graduates, and make sure that I stay close with them over their first year of practice. I remember one particular gentleman who last year was a new graduate. He was about a 46-year-old gentleman. He was a builder. And he hurt his back, and so he came to nursing. And so that was a lovely way of talking to him about, indeed, why he would choose nursing, and he also chose to work in aged care. So he was quite an extraordinary person, but it's only 8% of the workforce, and it needs to...
Because we don't put enough value on the caring professions?
Look, it hasn't changed, Madeleine, over years. It stayed at 8% for about 15 years, so it just isn't growing.
Ranjana? Blokes.
So,
thumbs up, thumbs down.
Oh, absolutely thumbs up. I have met some really obtuse female residents and medical students, and really astute men, and it's such a delight. And I think, honestly, I think medicine is producing more female graduates than men these days, just slightly, but essentially it's about 50-50. And I think that's reflected in practice, at least in the hospital system, where you meet great male interns and residents, great junior staff. What happens as you become more senior? Well, as you become more senior, as someone said, there's a very narrow place on the pedestals in medicine. It's a small place. And unfortunately, the research grants and the academic grants don't go to the kindest or the most compassionate doctor. They go to the doctor who produces the research. And I think that's where the tension becomes apparent between, am I going to be a so-called kind, compassionate, touchy-feely doctor, or am I going to do something groundbreaking that will get me that precious NHMRC grant? But at a junior level, I think we do very well. At a senior level, I think it depends on what profession you are talking about. The male-dominated professions are different to the professions where there is more equality amongst men and women.
But just to talk about the scandal that came out last year about surgeons and sexism and sexual abuse, effectively, of female surgeons. I mean, is that not an issue? Is there not a bloke-dominated culture still within medicine to a certain degree?
So where there is a specialty that's male-dominated, I think the culture is intrinsically different to something where there's more equality. Oncology, for example, has near equal men and women, a very different flavour to orthopaedic surgery.
Yeah. Right, okay. Where are we? This lady with her arm very straight. This might need to be our last question.
Okay, I'll keep it quick. I'm another Kate. My question really is, what are we doing to get health professionals to look after each other better? Reflecting on Ross's question, beautifully introduced by the question about sexism and abuse within surgical training, my observation as a physician and as a patient is that people who don't treat their colleagues well don't know how to treat their patients respectfully and kindly, and I wonder how we fix that.
Who wants to go?
That's a really interesting question, and something that I think about a lot. I think I don't know about fixing it, but we address it by showing respect and also by calling out disrespect, which traditionally we have been reluctant to do. And I wrote about this in The Guardian several months ago, about how doctors treat doctors is medicine's worst kept secret. We treat each other poorly. I don't think it's necessarily an act of commission as much as omission. I think we expect doctors to pull themselves up and look after themselves, hence the high rates of mental illness amongst doctors. And I think we do need to be a more supportive community. And somehow, the paradox is that we give our lives to looking after patients and caring for patients, and yet we don't nurture our own. And I think that discussing these things, talking about them, and people speaking up about the effect of not being looked after by their colleagues, and also conversely of being cared for in a supportive environment. I think all that helps. But we do have a long way to go towards self-care, no doubt about it.
Is that something that you think about, Lucy?
We celebrated International Women's Day last week on March the 8th, and it was really important. And so we had a panel of both physicians and nursing and allied health. We had an interesting topic that we had them debate. I think it is, it's finding ways, and that was a way to have a very contentious subject debated, and with about 80 or 100 people in the room. So I think we need to find different ways of doing it. You know, it's hard to contest amongst yourselves, and particularly if it's a small group of specialists, for example. So I think it's easier to find different ways to engage with these subjects, and we're trying to do that.
Kate, did you have any final thoughts on that one?
Not personally, but really just to echo particularly what Ranjana was saying about it's just vital. I absolutely agree with you that if you are able to care for your fellow staff, that creates an environment where, well, it just creates, if it's a team, as Lucy was talking about, if it's a ward, if the environment is one of caring and compassion for one another rather than hierarchical and based on fear, that's going to have an enormous impact on the patients as well. And not only that, on all of the staff that work there, the cleaning staff, right up to the consultant, I would think. And again, the idea of role modelling and that coming from consultant clinicians and then being spread out all around the various people that work within the team or within the ward environment, I would think would make an enormous difference. And it comes back to that idea about making mistakes too, because if you feel valued and supported and safe within your working team, I think you're far less likely to wipe any errors or shove them under the carpet and try to pretend that they didn't happen, that you will feel much safer to talk through perhaps with your supervisor, whether that be in nursing or allied health or medicine, what happened and how we might make sure this doesn't happen again. And that really, you can't do that if you don't feel safe and supported within your community of fellow workers, healthcare workers.
All right, well, we have run out of time, unfortunately, because we could talk about this a lot, but thank you very much for all of the very thoughtful questions. Kate and Ranjana's books will be on sale, as will my book, and it's actually, my book's called Guilt-Free Bottle Feeding, Why Your Formula-Fed Baby Can Be Happy, Healthy and Smart. And one of the areas that I dealt with a lot was lack of compassion by nurses and midwives towards mums, and on the breastfeeding issue in particular, and also how it's all about the baby rather than about the mum, and we forget about the mum. So that's, I could go on about that for hours, but I won't. But if I could just ask all of you to give a really massive round of applause to three extremely accomplished women, Ranjana, Kate and Lucy.
Visit wheelercentre.com for the best in books, writing and ideas from Melbourne, Australia and the world.